Hello, this is video number 3 for Respiratory Physiology. In this video, we're going to talk about gas exchange, and mostly we're going to focus on gas exchange in the lungs, but I will also mention a little bit about that happening in the tissues. In addition, I have a little bit of add-on information about lung volumes and capacities, and about a few respiratory conditions. So, first slide here shows gas exchange happening in the lungs. Here's an alveolus, the wall of the alveolus, and here's a pulmonary capillary surrounding the wall. Gas exchange involves movement of oxygen out of the air in the alveolus into the bloodstream, and movement of CO2 out of the bloodstream into the air. Now, I mentioned before that what's driving diffusion of gases is pressure gradients. So how is it that a pressure gradient is causing one gas to move in one direction and another gas to move in the opposite direction? So the answer to that question is that there are individual, what are called partial pressures for each gas. And these partial pressures can be opposing each other. And for CO2 and oxygen, they do oppose each other. So what determines these partial pressures, and how can we look at that more closely? So the partial pressures are defined by a concept from what's called Dalton's law. So let's look at that on the next slide. Dalton's law states that in a mixture of gases, the total pressure of the gas is determined by the sum of all the individual gases' partial pressures. So air is a good example of a mixture of gases. It has nitrogen gas, oxygen gas, CO2, and water vapor, water in gaseous form. The table that I have here shows each of those four gases, and when mixed together, what we have is atmospheric air. In the second column, I've broken down air in terms of the percentage of each of those four gases. Nitrogen, by far the most abundant. Oxygen, about 21%. CO2, only about 0.04%. And water vapor, around 0.5%. Now, the total atmospheric pressure of air is about 760 millimeters of mercury. So if we use this and multiply it by the decimal fraction of each gas, for example, for nitrogen, 0.786, the decimal form of 78.6%, times the total air pressure, 760, we get what's called the partial pressure of nitrogen. This is the pressure that nitrogen is contributing to the total air pressure. We can do that for oxygen, 0.21 times 760. We get a partial pressure of oxygen about 160. For CO2, the partial pressure is extremely low in atmospheric air. And for water vapor, about 3.5. All four of these, sum them up, and you should get a value at around 760. So the partial pressures are what are important here when we consider diffusion of gases. And we're going to focus in on partial pressures of oxygen and CO2. So let's look at that in an alveolus. On this slide, we're looking at the site of external respiration, gas exchange happening in the lungs. And here's air in the lungs, the partial pressure of oxygen and the partial pressure of CO2. And here's blood in the capillary, partial pressure of oxygen and partial pressure of CO2. Now, you might have noticed that these values here are different from what was on the previous slide. Oxygen 160, CO2 0.3. Remember, this is an atmospheric air. By the time you inhale that air into the lungs, it's going to be mixing with air that's already present in the lungs, and it's going to drive the oxygen content down and the CO2 content up. So by the time it gets to the alveoli, these are the partial pressures for each. Let's look at what happens for oxygen. In the air, oxygen 104 millimeters of mercury. In the bloodstream, about 40. So that's a pretty steep pressure gradient, and that's going to drive net diffusion of oxygen into the bloodstream. Keep in mind that net diffusion is describing most of the oxygen is entering the bloodstream. There can be some going the opposite direction, but by far most of the direction is going to be into the bloodstream. That's going to happen until the partial pressures of oxygen equalize. And when they equalize partway through this capillary, then there won't be any more net diffusion. There will be an equilibrium diffusion. Let's look at the situation for CO2. CO2 in the air in the alveolus, about 40 millimeters of mercury. In the bloodstream, about 45 millimeters. So that is also a pressure gradient. It's not very steep, but it still will drive diffusion of CO2 out of the bloodstream. And that will continue net diffusion of CO2 out until they equalize as this blood flows downstream in the capillary. Okay, so those are the pressure gradients based on the values of partial pressures driving oxygen into the bloodstream and CO2 out in the lung. Now, when this blood circulates away from the lung, it's going to go to the tissues. And this is the site of internal respiration, gas exchange in the tissues. So blood leaving the lungs, going back to the heart, being pumped to the tissues, is going to arrive with these partial pressures. Partial pressure of oxygen, about 100, 95 to 100. So that's down a little bit from what happened in the lungs. Just it decreases a little bit as it circulates away. Partial pressures of CO2, around 40 millimeters of mercury. How does that compare with partial pressures in the interstitial fluid? Well, for oxygen, about 40 millimeters of mercury. For CO2, about 45. So there's still a pretty steep gradient for oxygen, driving net diffusion of oxygen into the interstitial fluid. And still a gradient, not very steep, but at least enough to drive CO2 out of the interstitial fluid into the bloodstream. And again, there will be net diffusion, and then at some point, as blood flows along this capillary, they will equalize, and there will be, balanced equilibrium diffusion. So that's internal respiration. Now, I want to come back to this slide to describe a little bit about the rate of diffusion, and especially for oxygen. So in external respiration in the alveolar wall, there's a pretty steep gradient driving oxygen diffusion out. And if we look at when the pulmonary capillary first meets the alveolar wall and travels around it and then exits from the capillary, from the alveolar wall, then oxygenation is going to be happening in this, wherever it's in contact with the alveolar wall. All right, and you can graph that, and this is showing a graph on the x-axis time in the pulmonary capillary. Basically, this is where the capillary first meets the wall, and at the end here, where it exits from the wall. And time overall would be, a fraction of a second. In this case, about 3/4 of a second. Blood, when it first meets the alveolar wall, is about 40, partial pressure of oxygen of about 40 millimeters of mercury. So that's what's shown on the y-axis. And then very rapidly, within about 1/4 of a second, there's going to be massive net diffusion of oxygen into this capillary. So a pretty steep rise, and then it's going to plateau. Right here is where we reach equilibrium, equal partial pressure of oxygen in the alveolus and in the blood vessel. For the rest of the capillary, then, it's stably at that level. Okay. This slide summarizes partial pressures and the main locations that we've talked about. So in the alveoli of the lungs versus the blood entering the lungs. So steep gradient of oxygen, driving oxygen diffusion into the blood, and a shallow gradient of CO2, driving CO2 diffusion out of the blood. And now this is blood entering the tissues, and this is the interstitial fluid in the tissues. Again, steep gradient driving oxygen diffusion out of the blood, and a relatively shallow gradient driving CO2 diffusion into the blood. Right, brief mention about regulation of respiration. So the respiratory rate. You have voluntary control of respiration, but there's also subconscious autonomic control of that. And think of your subconscious autonomic control as operating when you're sleeping, for example. So what's regulating the rate and depth of breathing? So there are a number of sensory inputs into the control center for your respiratory rate. And this slide is a little bit busy here, but I'm going to point out some of the main features that I want you to notice. Blue are various types of sensory input into this respiratory control center, and this is in the medulla, and there's also one in the pons. I want to focus on this chemoreceptors that are present in some of the main arteries, for example, the aortic arch and the carotid. And these are reporting on different levels of especially CO2, oxygen, and changes in pH in the blood. So these are especially sensitive to changing CO2 levels. Elevated CO2 levels detected by these chemoreceptors will report to the respiratory control center in the medulla, and that will send out autonomic output to increase your respiratory rate and depth of breathing. Increased rate and depth will result in getting rid of more CO2, reducing CO2 levels in the bloodstream, and that's also going to change your pH, increase the pH. Brief word about a few different respiratory disorders. So just the basics here. One is asthma. Asthma is a chronic condition that's triggered by some kind of irritant in the atmosphere. So typically pollen, dust, pollution, things like that can be triggers for asthma. There are others that are types of asthma that are not triggered by such atmospheric substances, but we're going to restrict our conversation to those. When there's some kind of trigger that results in an asthmatic episode, it causes inflammation of the lining of the breathing tube, so the respiratory mucosal membrane, which causes constriction of the tubes, especially the bronchioles, which are pretty thin tubes. And that restricts the space for air passage. It also results in secretion of mucus, excess mucus, and other secretions. And the overall effect now is to severely constrict the passageway, air passageway. So in asthma, typical symptoms are difficulty breathing, shortness of breath, coughing, wheezing. Some treatments for asthma are meant to reverse those causes of the symptoms. So taking inhaled steroids, for example, cortisone can suppress the inflammatory response. So slow that down. And also bronchodilators can relax the smooth muscle in the muscularis layer, reopening the pathway. So providing a wider pathway for air movement. Another respiratory disorder is pneumonia. Pneumonia is the result of typically due to infection, bacterial or viral infection. And the infection is battled by your immune system, Typically, that results in accumulation of fluids due to the inflammation and also possibly the infection as well. Fluid accumulation in the alveoli is going to interfere with gas exchange. So pneumonia can be diagnosed by doing a lung X-ray, and fluid-filled portions, in this case it's a whole lung, but it could be a lobe or a segment. Those portions are going to be light on the X-ray because fluid-filled portions are going to let less X-rays through. Here, the right lung is clear, mostly clear anyway, showing much darker. Another example of a respiratory disorder is emphysema. In emphysema, there's an irritant causing chronic inflammation, and the chronic inflammation ends up degrading the walls of the alveoli. And as we discussed before, many alveoli share walls, and so when you degrade a wall, you get larger chambers, and you get these really large merged alveoli instead of the relatively small alveoli. These are non-functional, then they reduce the surface area as well. And not only that, but emphysema causes a loss in elasticity of the lungs. So there's more difficulty with being able to stretch the lungs in inspiration and also expel air in expiration. Emphysema is a progressive disorder, so the damage can't be reversed, but treatment for emphysema is meant to slow or stop the progression. For example, if it's due to smoking, and many cases of emphysema are due to constant heavy smoking, especially. If you stop smoking, that's going to stop that. Also can be treated by using bronchodilators to help open up the passageways. Finally, I want to spend some time talking about different ways to measure lung function. And this is through a technique called spirometry, which you are going to be using or studying in your lab course. Spirometry is a way to measure lung volumes that can be moved through breathing. So for example, there are 4 lung volumes, and they're shown on this chart as different color-coded segments. And on the y-axis is from 0 to about 6,000, 6 liters. And what's shown here is a tracing if you do quiet breathing. So within this light blue segment is the amount of air you move in or out by quiet inspiration, quiet expiration. I'm sorry about that. The average amount of tidal volume, the amount of air you move in quiet breathing, is about 500 mils or half a liter. Okay, you can also measure what's called the inspiratory reserve volume. This is the amount of air that you can take in, inspire, beyond quiet inspiration. So if you take a quiet breath in, how much can you suck in beyond that? That's the inspiratory reserve volume. And average volumes for that are around 3 liters. There's also the expiratory reserve volume, and that's the amount of air you can expire beyond quiet expiration. So if you expire quiet breath, then how much can you push out beyond that? And that's usually a little bit more than 1 liter total. The 4th volume is called the residual volume. So that's the amount of air that remains even after forced expiration. To measure your expiratory reserve volume, how much is remaining in all of the tubes and passageways and alveoli that you can't push out. So average values for that is around 1,200 mils. Now the capacities, and there are 4 capacities. The capacities represent sums of these different lung volumes that we just talked about. For example, total lung capacity would be the sum of your residual volume and the total amount of air that you can move, either by forced inspiration, the inspiratory reserve volume, or forced expiration, in addition to the tidal volume. The vital capacity is the sum of all the volumes that you can move. So inspiratory reserve, tidal, and expiratory reserve. It's excluding the residual volume. The inspiratory capacity is the total amount of air that you can inspire, both quiet breathing, tidal volume, and forced inspiration, your inspiratory reserve. And finally, the functional residual capacity is the amount of air that's the sum of the expiratory reserve volume and the residual volume. So this ends the videos for the respiratory system. The next set of videos will deal with the digestive system. See ya.